I'm a geriatrician, but I suspect a number of you would find it hard to actually write down what a geriatrician does. In fact, I suspect most of you wouldn't really know precisely what we get up to. And to be fair, within our own specialty, most geriatricians until a few years ago didn't really know why we did what we did. We did it and it seemed to work, but there wasn't a lot of science behind it. But that's changed, and hopefully what I can show you tonight is why modern geriatrics works, some of the science that underpins that, and then use falls as an exemplar of how we put that into practice. So let's give that a go. If you go to the Royal College of Physicians website, this is what they'll tell you geriatric medicine is. So it's a branch of general medicine. So we're all trained as general physicians, we can do the acute tech along with everybody else. But then all it really tells you after that is that we've got something to do with old age, something to do with looking after old people, and doesn't go into a lot more detail than that. So I suspect the Royal College doesn't really understand what we do either. Ageing has obviously got something to do with it, and hopefully this definition of ageing will be familiar to some of you, but perhaps not all. Every book you look in will define it in a different way. This is one we've been using at George's for about 20 years, and it seems to work quite nicely in a clinical environment. So the first thing is that it's a progressive generalized impairment of function. Every organ in the body is affected to some degree. It's at different speeds in different organs, but you don't wake up one morning feeling old. You feel it, but you're not. Does anybody know when you can see the first change of aging? And some of you might have covered this in the course. So what age do we start to see a change that we can measure? 20-something, 30-something, 40-something. It's actually 14, 1-4. That's when your eyesight is at its optimal function. From then on in, it's downhill. Now, the thing you notice is being able to see things in the dark. When you're 14, you can see everything without any lights on. About 10 to 12 years, you need to double that illumination. Now, double not much is still not much. But believe me, by the time you get to 50, trying to see what's going on in the dark starts to get quite hard. And by the time you're 80, it's almost impossible. And every organ is affected in that way. The result of this is not catastrophic, but it's the loss of the adaptive response to stress. So you can go on into your 90s, up to 100, and as long as you can avoid pathologies, you can actually live very healthy, very independent lifestyle. But if you get sick big. It all falls apart very, very quickly. And that's what's characteristic about aging. It's not a loss of function, it's that loss of reserve to deal with the stresses when they occur. And then we have to recognize that as we get older, there are certain diseases just become more common. So most cancers, cardiovascular disease, neurodegenerative disorders, they all increase as we get older. So this is all part of aging. But if you can avoid the pathologies, you can actually remain healthy and independent right into your 90s. And I get to meet a lot of these people. I'm very privileged to do that. So aging, as a definition of who needs a geriatrician, isn't really very helpful. Fortunately, the concept of frailty has emerged in the last 10 years, and this is actually much more useful in defining what we do and understanding why what we do works. Frailty is a physiological syndrome, and it's got these characteristics up here that you can see. There's a change in reserve diminished resistance, and the most important thing is that there's worse outcomes with everything if you have the frailty syndrome. Now, not all old people are frail. Over the age of 65, about 10% are. And of course, there are some people younger than that who are also frail. When you get to 80, it's about a third. When you get to 90, it's about 50%. And this group are different to other healthy adults in that they're much more prone to have these bad outcomes. And bad outcomes, I mean mortality, morbidity, complication rates, length of stay are all much higher once you've developed the frailty syndrome. So if we can identify it in our patients, we may be able to manage them in a different way and perhaps get better outcomes for them. There's different ways of spotting frailty. To a geriatrician, you walk into the room and you can usually spot it, where other people may not. But there are tools to help us do that. So one that's commonly used is the frailty syndrome, which is a distinct phenotype, and there are 5 different characteristics. And if you've got 3 out of the 5, then you qualify to have that. Weakness is probably the most important one. The loss of muscle, sarcopenia, is really central to a lot of what we see going on in frailty. Slowness, and the easiest one to measure there is gait, so a simple get up and go test. So you measure the time someone takes to stand up from a chair, walk 5 meters, turn around, walk back and sit down again. And you can, people who this is slowing rapidly and are developing frailty. They have low levels of physical activity, they report being exhausted all the time, and there's unexplained, unintended weight loss. And often this is muscle, but there's some fat that goes with it as well. So that's a fairly easy phenotype that you can use to identify people with this trait. Another way of looking at it is something called the Frailty Index. And this is where you carry out a very comprehensive assessment of an individual, looking at all sorts of different characteristics, the CGA, and I'll come back to that particular tool later on. And often up to 80 different characteristics are looked at. And if people have developed over 30, normally you're saying they're going into the Frailty syndrome. This tends to be more of a research tool than a clinical one because there's so much to it. But it is very useful. The deficits have got to be acquired. They've got to be age-associated. They must be associated with an adverse outcome. And most importantly, they mustn't saturate too early. So really good example on this one is benign prostatic hypertrophy. Pretty much every man at the age of 65 has got this to a degree or not. So it doesn't discriminate. It's no use as one of these. Whereas loss of cognitive function clearly is a negative thing and absolutely isn't universal, so is a very useful one of these frailty indicators. Why does all this happen? Well, this is still a very early science. People have recognized it for just over 10 years, and the heavy research has really only just started. We know that there are certain etiological factors. Within these, aging, that's the American spelling of the word, by the way, rather than the English spelling, which has an E in it, is definite. Genetics is important. We see some families are much more prone to develop frailty than others. Lifestyles, particularly sedentary. Diseases, diabetes being the most recognised one, and then environments. People who live in poor environments, those in poverty, those who are overcrowded, much more likely to develop these problems. The mechanism is probably through chronic inflammation. We see that there are raised levels of cytokines and appropriate molecules, immune cell levels go up, and there's an inflammatory pathway activation. Some people are keen on CMV being the trigger. I don't think that's really proven yet, but it's still out there in the research. These act through various systems. The musculoskeletal is definitely one of the main ones where you see so much cellular loss, but endocrine systems, growth hormone levels, for example, drop and become less cyclical. Some changes in the cardiovascular system, particularly compliance of arteries, and hematologically, they're often running a chronic anemia without any other specific cause. These lead to the frailty phenotypes, so weakness, weight loss, exhaustion, low activity, and slow performance. And then these lead to the outcomes that we end up seeing as clinicians, so falls, disability, dependency, and death. So we're beginning to get a model that underpins frailty, and frailty is really where geriatricians need to be. So a quick case for you. 92-year-old lady goes to her family doctor. She's had 3-day history of a cough, green sputum, lethargy, chills and rigors. She gets examined, she's tachycardic, febrile, and she's got crackles at the base. I'm not going to insult you by asking you the diagnosis. She's clearly got pneumonia. It's easy. The treatment, 5-day course of antibiotics, and send a nurse around after a couple of days just to make sure she's recovering as she should do. It's easy medicine. Another case, 84, so actually younger. Comes to A&E, she's been found on the floor by her carers. She's too confused to be able to give a history. She's drowsy, she's hypothermic, she's dehydrated. Now, as I'm sure you all know, underlying that could be a whole multitude of different diagnoses. However, it's the same diagnosis. She's also got a basal pneumonia. However, her presentation's completely different, as is her treatment. So she requires coming into hospital, intravenous antibiotics for a week, IV fluids because she's not drinking and she's already dehydrated. She's bedbound for that first week. It's then 2 weeks to get her out of bed. It's then another 6 weeks in a rehabilitation centre before you can even think about getting her home. So exactly the same pathology, but an entirely different presentation. requiring totally different treatment. The difference, even though the second case is younger, she's got the Frailty Syndrome, she's got all the problems go with that. The 93-year-old, previously fit and well and strong, and handles it just like a younger person. The first patient shouldn't be under a geriatrician. The second one would definitely benefit from some input for us. So that's what geriatricians are after. It's these patients with frailty on top of everything else that is really our raison d'etre. The disease presentations change. Part of that's age, so that when they get ill, they get hit very hard and all sorts of systems start to collapse very quickly. This leads sometimes to these very non-specific presentations, falls, confusion, etc. Signs and symptoms are sometimes missing. It's very inconvenient. They don't get the crackles you're expecting. They don't. You can see peritonitis with no guarding and tenderness at all. They always have more than one thing wrong with them. Most of my patients have probably got 7 or 8 active pathologies at one time, rather than one simple one. That means they're on lots of drugs. And as they're already more sensitive to the drugs and get more side effects in the first place, this just creates chaos. So this is all fun for us to get involved in and try and sort out what's the right drugs for that individual, rather than just slavishly putting them onto yet another protocol for their latest disease. Back in the 60s, Bernard Isaacs described the Geriatric Giants. It's a rather cruel term, but it works. 5 different presentations that we most commonly see, all of which could have any diagnosis underlying them. You'll see lots of different iterations of these. I particularly like this one because they all begin with I, so it's easy to remember. So immobility, suddenly not being able to get out of bed, get out of the chair, instability, falling over, intellectual impairment, so that can be acute delirium, or it may be a chronic dementing process, or more frequently both. Incontinence, urinary, fecal, or both, and then this inability to manage activities of daily living. So this is not being able to wash yourself, dress yourself, feed, all the things we have to do on a daily basis to survive. You suddenly lose that function. And these are the presentations that we often see. How do you handle them? Well, now we have a very clear way of managing these patients, and the tool is the comprehensive geriatric assessment. It's multidimensional. It involves looking at all aspects of the patient, and it's multidisciplinary. Physicians on their own can't do it. You've got to have therapists, nurses, speech therapists, dietitians, a whole team. So geriatricians, yeah, we're of some use on our own, but if you want to get the best out of us, you need a whole team to make it work really, really well for the patient. There are lots of different models out there, but this is one that works reasonably well. So there are medical elements, which are clearly going to be the doctor's responsibility, doing the diagnoses, making sure they're treated properly, reviewing all of the medications. It's amazing when you go down a medication list, nobody seems to know why people are on half of them. They're historical and no one's thought to stop them. So that's always a good thing to do. Looking at the nutritional status, trying to create a problem list. Generally speaking, we also end up doing the mental health. You might get a psychiatric colleague, but often we'll manage most of that. There's then the functional capacities about exercise, tolerance, gait, balance, and this is where we need our therapy colleagues coming in to work on this. Social circumstances, so who's out there to help, what are the social networks, what can they access, and also the environment. What's their house like? Have they got steep stairs they've got to get up and down? Are they all on one level? All these sorts of things, and this is where nursing staff, social workers, etc. will all come in. So it requires a whole team to get this assessment. And that takes time. It's not something you can do in a hurry. And from that, you then create the list of problems that you need to solve. Does it work? Well, yes. And we've been doing this for a long time, but now we have a lot of evidence to prove that this is the best way to manage patients. This is a really good paper. It's from Daniel Harari et al. There at Guy's and St Thomas's, so just down the road from St George's, published back in 2007, so it's 10 years old now, but it's still only just beginning to get going within health structures. They created a team that they called OPAL, Older People's Assessment and Liaison, and essentially what they did is they screened all acute medical admissions over the age of 70 coming into St Thomas's for a medical admission. They either then rapidly transferred them to a specialist geriatric ward, or they kept them where they were and managed them with the medical team inputting and giving advice. And they looked at historical data and what happened when they did this. What they found is pre the implementation, none of the people who come in with a fall were getting referred into fall services. And we know full services work. That's been evidence-based for a long time. Post-it, 92% were getting there, so much better care of this problem. Delirium, chronic pain, constipation, urinary incontinence, all the same. They started to get put into the right pathways rather than the problems just being ignored and sent back out again unsorted. Twice as many patients got to the geriatric wards, and they got there quicker, an average of 3 days rather than 10. And then probably the most striking thing is that they managed to reduce the length of stay by 4 days. Now 4 days is a lot. That's the difference between having a hospital that is stuffed full and can't function to having 85% occupancy, which is exactly what you want. And for a patient, getting out 4 days earlier is also a huge bonus. So this definitely works, this approach. There's studies using these models now in surgical wards where you've got geriatricians going in and working with the surgeons. Most evidence is around hip fractures, so pretty much every hip fracture now in the UK is jointly managed by a geriatrician and a surgeon, and we've seen, again, big improvements in an area that had terrible outcomes beforehand. They're not great still, but they're an awful lot better than they were. It's been done in the community. The only area where it hasn't appeared to work yet in the studies is A&E. And I suspect that's because the turnaround is too quick. It takes quite a long time to do this whole assessment and put it into place. And most A&Es, I don't know if you're aware, in the UK, there are national targets that you have to have everybody in, assessed and out in 4 hours. You can't do this in 4 hours. But you can start it. So at least if you're identifying people, you can perhaps put them into the pathways to get it done. But everywhere else where it's been tried, it's a proven model now. We know it works, and it has this understanding of frailty backing it up. I wanted to come back to this model because, of course, we've only looked at this end. So once people have become really frail, we've now got a model of care that can improve their outcomes. But what about if you can get back earlier into the process and actually identify the beginnings of frailty at a very early stage? Can you slow it down? Can you perhaps stop it? Possibly even reverse the whole thing? We don't know yet, but there's a lot of studies particularly looking around exercise. Sarcopenia really seems to be key to a lot of this. So many of the trials that are going on presently have an exercise component to them. And that data should start to come out in the next few years. And I think probably for us in this room, and certainly a few of us, that's going to be very important because probably if you want to stop frailty, you've got to start doing something about it in your 40s to 50s, I would guess. But let's wait and see what the data shows. Another case, this is one I looked after, probably getting on for 20 years ago now, if I'm honest. So this is a lady who'd come into St George's. She'd had a fall at home. She hadn't broken anything, but since she'd been in hospital, she could not mobilise. She absolutely claimed that previously she was entirely independent at home, and if only silly doctors would let her go home, she'd be absolutely fine. Cognitively, AMTS, I know it's crude, but that's all we did 20 years ago. It was pretty much okay. Not a lot on most of the examination. She was a bit constipated. She had almost no passive movement in her hips. They were completely locked solid. And she had pressure sores on both her heels. But she didn't come in with those. She acquired them while she was in the hospital. Investigations, really not a lot, apart from very arthritic hips. She did have an E. coli UTI, but actually treating it made no difference. It wasn't the reason for her presentation. So she got transferred across to my ward. When she arrived, she still needed 2 to 3 to transfer out of bed into a chair. She needed help with washing and dressing, but she still absolutely insisted if we'd just let her go home, she'd be fine. And I'm not sure why, but we actually decided to do that. And we took her home, probably because she only lived around the corner from the hospital. So myself and a physio and an OT went to her house with her in a wheelchair. And this is what we found. This was her chair where she sat all the time. Now, these used to be fairly standard issue chairs. They're very high. They've got a big high back, nice arms you can push up on. But she'd added about 8 inches of extra cushions onto the top of it. So she would just fall back into the chair without bending her hips, and then she'd just push herself back up into an upright position again. She perched rather than sat. That's her bed. Again, looks fairly standard, but she'd actually got the neighbours to add extra mattresses. And again, she would fall onto the bed, swing her legs round, and to get out, she would pivot her legs round and come up in one movement into an upright position. And then this was her stairs. These are old Victorian staircase. They're very steep, but I hope you can see, she got the neighbour to nail a bit of extra wood on the wall there, and she went up and down like a crab sideways. So she never had to actually flex her hips. She could rock her way up and down the stairs. So she'd fixed all the problems, which we failed to understand. So why did we get it wrong? Well, we understood the biology. We knew what the pathologies were. We were very clever about that. What we didn't look at, we didn't understand this particular lady's psychology, just how determined she was to be independent at home. And we certainly didn't understand the social factors, how she'd adapted her environment in her own way, and how she had very supportive neighbours. So we hadn't got the whole biopsychosocial model clear, and that's because we didn't do a comprehensive geriatric assessment. If we'd have done that, we'd have known all these problems. We'd have probably had her home a fortnight earlier. So it just makes the case as to why this approach really does work in reality. So I want to show you a little bit about falls and falls management. This is probably the commonest presentation that we see as geriatricians. A very high proportion of our patients come in via this route. What do we know about falls? I don't know if any of you recognise this particular scene from a football match a few years ago. Mr. Rooney, who's the one in white standing there, doesn't know a lot about falls. He can't work out how the guys ended up on the floor. Mr. Ronaldo, who's rolling around on the floor, he knows a lot about falling over. He's apparently very good at it. We know a bit. We know that falls are very, very common. And we've known since the 70s that once you reach the age of 65, a third of the population will fall each year. Stephen Lord, who's in New Zealand, I'm lying, he's in Australia now, has done a lot more detailed work on it more recently. And what he also shows is that the older you get, the higher the percentage goes up, but also you're more likely to become a serial faller. So most of the 65-year-olds, they'll have one fall in a year, it's an accident. You deal with it, that's often the end of it. But once you're into your 80s, particularly over 85, you're almost certainly going to have a second, a third, a fourth fall. It's a real marker of something that's going badly wrong, and that's important. We know lots of risk factors for falling. In fact, when I was a registrar, this was the area of research, and we were all racing, could we publish the next one, do a bit more epidemiological work and find another reason why people fall over. It was quite satisfying, but it didn't really add much to patient care because most of the risk factors we found you can't change. They're fixed. There are some you can, so vision, lower limb strength, changing medications, but most of them don't really add to clinical care. They're just an academic exercise, really. We've known about some of the consequences for time immemorial, really. The most obvious ones are the physical injuries. So if you fall, fractures, soft tissue injuries and head injuries. And I don't know about you, but I'm seeing a lot more head injuries than I used to look after. And I think a lot of that's to do with the fact that we're now anticoagulating an awful lot more people. So everybody with AF didn't used to go on warfarin or one of the DOACs. Now they do. And I think I'm seeing a lot more subdurals as a result of that. Overall, it's probably the right thing to do still, but this is just one of the unintended consequences. If you're stuck on the floor for long enough, you'll get a pressure sore. Anybody know how long it takes to start a pressure sore?
4 hours?
1 hour. 1 hour, if you don't move at all, your skin will be blanching by that stage. But if your blood pressure is low, it'll be even quicker than that. Now at an hour, get them off it, it reverses very quickly, but it really does happen very fast. So on the floor all night, if you can't wriggle, you're in trouble. Now, I don't know if you see this next one very often here. Ooh, what have I done? Do you see much hypothermia? No? We get lots, as you would expect, mainly because our housing stock is so poor. Apparently you don't see it in Scandinavia very often amongst the elderly population because they build their houses properly and they turn the heating on. In the UK, our housing stock is very poor and everybody, including my own parents, wouldn't put the heating on because you couldn't afford to pay the bill, could you? You get hypothermia instead and go to hospital. So if you fall over, in the UK and you haven't got the heating on at night in the middle of winter, there's a real risk you're going to end up with hypothermia. It's yet another danger of a fall. These are the obvious ones. The area that we've only become aware of really more in the last 20 years, definitely the last 10, is the psychological impact of having a fall. If any of you have fallen over walking along the road, the first thing you do is you feel really stupid. And then you think, well, I wonder if I've hurt myself. And usually you haven't. So you get up and you look around to see if anybody else has seen you. And you try and scuttle off as quickly as possible to avoid the embarrassment. The impact on an older person is much greater. They start to doubt themselves. They start to restrict their activities and they reduce their mobility. There's the idea of living in an ever-shrinking world. So first of all, you're going everywhere, doing whatever you want. You have a fall. Oh, I'll just go to the local shops. I won't go any further than that. You have another fall, I better stay indoors. You have another fall, you stay in one room, and eventually you end up in institutionalization in a nursing home, which is terribly sad because if you actually put in the right rehabilitation, which involves rebuilding that confidence after the first fall, you can stop all of this happening. But that psychological impact is just as important as the physical one. Now, as physicians, we spend a lot of time trying to find things we can treat and cure. And with falls, our approach used to be no different. We loved finding the cardiac arrhythmia, the postural hypotension, the new diagnosis of Parkinson's disease, the thing we could potentially fix or at least improve and stop people falling over. The reality is that only accounts for less than 15% of falls. So although we were working away very hard, we weren't really having much of an impact on the global number of falls that were happening because we were just looking for these ones. I'll say simple, they're not simple, they're hard to find sometimes, but once you found them, you can fix quite a lot of them. The other 85% of patients we were really ignoring and not really addressing their needs. This is a study that was published in The Lancet, when was it? 2012. It's a really good online video that goes with it as well if you want to have a look. I won't try and play because it's bound to go wrong. But essentially what they had is they had video cameras up in a whole series of nursing homes and they filmed the corridors and as a result they were able to catch people falling over. And they ended up with 227 falls in 130 individuals. And in well over 80, around about 85% of them, these falls occurred during normal walking, just getting up from one chair and turning to sit on another one, leaning on something, the thing slipped and they fell over. These were all about strength and balance problems. That's why they were falling over. And this was the first time that we had this number of falls all documented, that we could actually see what was going on. People telling you why they fell over is terrible. They haven't got a clue most of the time. So documented, objective evidence was really powerful. And it showed that yes, we must keep looking for these rare items, but actually to manage falls effectively, we've got to manage this other 85% where the problem is their musculoskeletal strength, their balance, and all of these areas. So if we look at the evidence base for falls management, we can divide it into primary, secondary, and tertiary. Primary is about trying to stop people falling over in the first place. And we've known we can do this for a long time. Meyer did the first studies, but trying to implement it has proven to be much harder. Probably the best study is from Campbell from Dunedin in New Zealand. What he did, he had female subjects, all aged over 80, they could walk around their own home, and they hadn't had any physiotherapy. Put them into an exercise program of muscle strengthening and balance retraining of increasing grades of difficulty. They had a physiotherapist go around to their home, 4 visits over 2 months, individual, one-on-one, teaching them how to do the exercises, grading them up each time. And then in between that, you had to exercise 3 times a week and go for a walk 3 times a week. The control group got medical students with cake. So they went round and spent the same time with the older people as the physio had been doing, but eating cake and tea with them. I quite like the control group. I think that's one of the better control groups going. So they had the same person-to-person contact, but the outcome was very different. 2 years results, 138 falls in the subjects, 220 in the falls, relative risk of fall 0.69, relative risk with an injury 0.63. I should have put the p-values up as well, but it did reach quite significant difference. So they showed that you could reduce falls by an exercise program. When you put all the primary prevention studies together, it very much shows that you can't do this to the whole population. It's very intensive. So the first things you've got to do is trying to identify the group that are at most at risk of falling. Sometimes that's easy, sometimes that's harder. And then you need a simple, multi-dimensional intervention, but it must have an element of strength and balance training within it. You can do a check of the environment, you can look at all of the drugs, and that adds to the exercise, but if you don't do the exercise component, any of the others on their own don't work. So the exercise is really, really key to primary prevention. Secondary prevention, so this is where you've had a fall and you're now trying to stop the next fall. This is the best study for this. This is Jackie Close's work. This was at King's, so again in South London. It's been a bit of a hotbed for research. Interestingly, she's now married to Stephen Lord from Australia, as they met at a Falls conference and fell in love. And it was a choice of Melbourne or Denmark Hill in London. They're in Melbourne. If you don't know Denmark Hill, you won't be surprised as to why they chose Melbourne. And they're pumping out papers like nobody's business between them. What did she do? She took people over 65 living in the community who came to A&E with a fall. They didn't need admitting, and she brought them back to what was a day hospital. It's essentially a clinic. And they had a very comprehensive assessment with a doctor and an occupational therapist. And then all of the problems that they identified, they then referred them to the relevant services that already existed. But it was this one-off, very comprehensive assessment that the thing that was different. Controls just got usual care, which basically was a sticking plaster and off you go. The results, 183 falls in intervention group, 510 in the control group, a phenomenal p-value that we would all kill for. They've now got data going out to 3 years from that initial intervention showing that that one-off intervention is still showing a difference between the groups 3 years later. It's incredibly powerful, and it's essentially a comprehensive geriatric assessment, which we now say is our stock tool. So secondary prevention, what are our keys here? It's the CGA. And then on top of that, if there's anything that specialists that needs to be looked at, so studies for syncope, etc., you do those. And then you have an exercise-based program as well. So exercise, yet again, comes in as important. Finally, in the prevention, we've got tertiary prevention. So this is where you just accept whatever you do, some people are still going to fall over. You can't stop them all. But can you reduce the impact of it? I want to look at 3 different areas: vitamin D, hip protectors, and flooring. So vitamin D has had an interesting history, but Chapuis started it all off. Chapuis was a French physician, and she had 3,270 females, mobile, living in French nursing homes. Now, French nursing homes are apparently very different to UK nursing homes, where pretty much nobody is mobile. So they're obviously talking more about equivalent of a residential home or living at home with support, but they don't go out of doors. She gave them 1.2 grams of calcium and 800 international units of cholecalciferol a daily for 3 years. She picked that dose because that was the size of the tablet. There was nothing scientific about that many units or that many grams. It was just convenient. She showed a significant reduction in hip fractures. Now, this was an interesting paper because it showed a difference, but it actually asked more questions than it answered. She didn't measure the falls rate, so we don't know whether people were falling over less or whether their bones were just healthier, so when they fell over they didn't break. We didn't know if this was the optimal dose of vitamin D, etc., etc. And if you followed the history of vitamin D since then, it's gone on and arguing. There was one stage they wanted everybody the over age of 65 on vitamin D, including the so-called free range, those that are out and about in the sunshine. Then they decided that wasn't a good idea. I think where we are now is people who are deficient absolutely need that corrected. People who are housebound and never see any sunshine, they should certainly be on supplementation. Healthy, normal adults almost certainly don't need to be on calcium vitamin D unless they already have established osteoporosis. The UK government has taken an interesting step recently where it won't pay for most people's calcium and vitamin D now. They're asking GPs to stop prescribing it unless they're frankly deficient. So it makes me worry that we're going to see another surge in vitamin D deficiency problems. Holland and Barrett, which are the local chemists' health shop who sell it, they're delighted because they know they're going to make some money, but I'm a bit worried by this. Now, hip protectors. Don't know if any of you have ever seen a pair of these. Rather natty. They are essentially a protective shell stitched into your underpants that fits over the femoral head. It's the same material that you make shin pads out of. So those of you who want shin pads for hockey or football, it's the same stuff, but it's in your pants. Do they work? Absolutely. There's never been a fracture recorded from a fall while you're wearing them. However, even in the studies, the compliance was only 24%. And when you get into the real world, it's less than 1%. Why? Well, you only get 2 pairs. All of my patients have got continence problems, so how 2 pairs of underwear is meant to keep them going, I've no idea. They're really quite hard to get on and pull up and get them snug over the right places. They make you hot, and they make you look fat. So a lot of people really don't like them, and they won't wear them. There are 2 exceptions. If you've got very skinny, very osteoporotic, high risk, highly motivated females, they will sometimes wear them because they know if they fall, their hips bust. So they're motivated to do it. And then the other group is almost the opposite. They're the very demented patients who like to wander. So I'm sure you've met these. Some patients with dementia, they just like to walk around and move and see what's going on. And if you try to make them sit still, they absolutely hate it. And it's the worst thing to do to them. But of course, they are at risk of falling. And there you can sometimes get the carers to put them on and change them regularly, and you put a pad inside to kind of keep them dry. So they are effective, but they've got enormous limitations because of the design. Now, people have tried to develop on this and look for something that's more useful. So they've come up with a belt that has airbags in it. So the idea here is a similar technology as you have in your car. When you start to fall over, the bags inflate around your hips, and you'll fall onto the bag and your hip is protected. The theory is great. Unfortunately, in the early trials, what happens is you bounce and you land on your head. So you end up with a head injury rather than a hip injury. They also go off in lifts and elevators. So if you're going down too fast, that's the trigger. Your skirt's suddenly up here in the lift. But, you know, the idea is a good one, and people will continue to develop this sort of protective wear. You know, if you look at motorcyclists, they can come off their bikes at 100 miles an hour and just slide down the road and get up. So there's lots of materials out there that potentially could be used to protect older people who are at high risk of falling and breaking things. So it's a good thought. Hasn't quite worked yet. Flooring is very interesting, and this is from this year, in fact. No, sorry, last year. They took 20 bedrooms in a subacute geriatric unit, and half of them they put on very thick, spongy flooring, so that if you landed on it, it wouldn't hurt. Didn't change the rate of falls. You wouldn't really anticipate that it would, but it did significantly reduce the injuries and the fractures. So by adapting an environment, you can sometimes make things safer. The challenge is that you couldn't move the furniture around on it very well. So in hospitals, the beds weigh a ton, don't they? And the lockers are all really heavy. So trying to push them around on this floor that was going like that wasn't easy. So in fact, they've abandoned it purely for pragmatic reasons. But the idea worked, and now they're looking at other ways of being able to make something that will take just dissipate the impact without having that same negative approach. Actually, you're probably all young enough to have played in playgrounds now where they have this soft stuff on the floor when you fall off the swing. I used to fall on concrete. But now they have this shredded tyre base, don't they, that you fall onto. That's also being used around residential homes and in pavements where there's a high traffic of older people who are likely to fall. And it's thoughts like this of making the environment safer that may have a really useful impact. So, we know exercise works because balance and impairment and muscle weakness are the most prevalent risk for falls. We know that it can be therapeutic exercise is the most effective component of a multifactorial intervention. Tailored programs can reduce falls by up to 54%, which is better than most drugs you'll ever prescribe. But not all exercise works. It's got to be the right sort of exercise. It's got to challenge balance and strength and improve them. It's got to be tailored to the individual. It's got to be progressive. You've got to do it 2 or 3 times a week for it to work. You've got to do it for at least 50 hours. And you need proper trained instructors to really make it happen. So it's not cheap, but it is effective. And compliance is a challenge. I'm sure you're all very good at going to the gym on a regular basis. I wouldn't go. And if a physio gave me some exercises to do at home, I'd probably do them for the first few days, and then I feel better now, and I'd stop doing them. So keeping yourself motivated on your own is not easy. What works? Tai Chi is very good. I don't know if you've ever seen Tai Chi being done. There's some great classes around Tooting. You go down and there's these muscle-ripped gentlemen at the front standing on one leg and rows of 80-year-old ladies clinging to his every move on one leg. It's quite amazing what they can do. That works, as does dancing. Ballroom is the one that's been looked at in particular because it's about balance, it's about strength and coordination. And gardening, apparently, is also very good for primary prevention. If you've had a fall, then you want a more structured approach. The Otago is the one that's come out of Dunedin, Campbell, the study I showed you there. The Postural Stability is the UK equivalent. These are ones led by instructors, very specific. Chair-based exercises, or chair aerobics, as they're sometimes known. You have a chair and you start exercising in the chair, and then you might walk around the chair holding on to it. That doesn't work, but it might get you confident enough to then actually engage in some proper exercise that will help. Nordic walking and yoga, good for your cardiovascular, good for your general fitness, don't stop you falling over. Interesting how some things really do seem to work and others don't. Presumably it's the part of your body, the function that they're working on that makes a difference. Now, moving right up to date, people are starting to look at smartphones and tablets. And the first one, and many more of my patients are now starting to have these, which is great. You can get an app that will prompt you to do your exercise and then talk you through what you should be doing. So do so many of these, do so many of that, work your way through. And there's some evidence that this does actually improve compliance and is potentially a cost-effective solution. Once you've written the app, you can just give it to people and encourage them to use it. And it might be a useful follow-up to a couple of sessions with the exercise instructor to move them on to this. So that's pretty good. Exergames and volitional step training seem to be even more promising. So exergames are these things that you've all played on the Wii. So you stand on your balance board and you ski down the slope, or you make squares go around hoops and things on the screen. That works, and it also works for older people. And the volitional step training is where you do multiple steps in one direction. And that's because when you're about to fall, one of the protective mechanisms is to stagger. And if you can do that effectively, you can often avoid falling over. And of course, they're all on the dance mats, which I've seen my kids on. Yes, I certainly wouldn't get on one. But apparently, that can work very well for older people as well. If you get the songs right, you get the rhythm right, getting them stepping in the right direction, it can all be very effective. Quite a lot of my patients are doing line dancing now, which I suppose is actually doing the same as this and probably giving you the same input. So this looks very promising to get people doing stuff in their own rooms and having some fun doing it. I wanted to mention dementia because, again, you can't avoid it. We're going to see more and more and more. And if you've got dementia, your risk of falling is so much greater than in someone without dementia, particularly when you move them. So I have so many conversations with families saying, well, mum keeps on falling over at home, so we're going to move her into a nursing home. And my answer or advice to them is, she won't stop falling over. She'll probably fall over more. She'll get found quicker, but it won't stop the falls. Don't do it just for that. If they break their hip, their mortality is absolutely appalling. It's bad as it is, but 71% are dead within 6 months of a hip fracture if you have dementia as well. So trying to avoid hip fractures in this group is absolutely vital. A lot of therapists, old-fashioned, not up-to-date, will tell you you can't rehab a patient with dementia, you can't improve them. They talk about a thing called carryover, which essentially is being able to remember what you learnt in the last session when you do the next session. If you can't even remember you've had a session or who the therapist is, you obviously haven't got carryover. But there's lots of evidence now that shows that that isn't the only thing. Actually going through the exercise program is valuable. This is a great study from Finland. Finished in 2013, but has only just been published. They had 210 home-dwelling patients with dementia, and they put them into 3 different groups: home exercise, class exercise, normal care. They were able to show very significantly, these are your control having no exercise, both the group exercise and the home exercise, massive reduction in the number of falls that they're having. They didn't show a difference in fractures, but I think that's because the numbers were just so small. It didn't get there, but it certainly was reducing the falls. And when they broke it down, they found that those with advanced dementia, the impact was greatest around the falling. Those with mild dementia, it was about physical functioning and improving their well-being that they really got the most out of it. So it worked at both ends of the spectrum, and is certainly worth doing. While we're on dementia, acetylcholinesterase inhibitors, I'm sure most of you are familiar with. So these are drugs that are given very crudely in Alzheimer's to raise the level of acetylcholine within the brain, because we know it's low. It doesn't change the underlying pathology, but in patients who respond, it does slow down the cognitive loss and give you about 2 years of increased independence. They've now started to trial them looking at gait, and this is one study of rivastigmine in Parkinson's disease. It's only a short trial, it's only a phase 2, but they showed a 45% reduction in falls per month in the group studies. So it needs to be repeated, we need much bigger studies, but it's interesting that influencing the acetylcholine levels might change our falls incidence. I think I'll skip that. Right, that was nice. They're worth skipping a lot of the time, although they do come out with some good stuff. When you're assessing a patient, I know you're all going to take a history. I did a lot of research a few years ago, basically going through notes, reading what people have written in their histories. I had about 300 patients, and it's amazing what gets left out. So I'm not going to tell you what to do, because you know what to do, but please do ask about the fall. Amazing how many things. Patient complained of fall, and that's the last you hear about it. You want to know what they were doing before, what happened at the time, what they felt like afterwards. This is the real bit. If you do nothing else, find out what dizzy means. Patients will tell you they're dizzy. Do they mean they're vertiginous, they've actually got vertigo? Do they mean they're pre-syncope? Do they mean they've got disequilibrium? Because the diagnosis is different for everyone. But again, you'll find just that written in medical notes again and again. So avoid doing that. It takes a bit of time. Patient needs to often be facilitated to describe the sensations that they're getting. But it's really worthwhile to help you understand what the problem is. On the examination, you're going to do a full examination, but again, the bits I kept on finding missing were lying and standing blood pressures done properly. So I'm sure you all know they've got to be fully rested flat, take their blood pressure, stand them up and continuously measure it for 3 minutes. Hardly ever get that done. You ask the nurses to do it, they will not do it that way. If you want it done properly, you have to do it yourself. A neurological examination is quite handy, and bizarrely, out of these nearly 300 patients, only one had a gait analysis. When you do outpatients, go and get the patient yourself and bring them in. You'll often know why they're falling over before you've even got them in the room. It's so obvious when they stand up and they're swaying all over the place. So watch them walk. It's really, really helpful. But it doesn't get recorded. When it comes to investigations, we have a bit of a plague of CT scans at St George's. So everybody who comes in seems to get a CT scan. They really don't need it. You only need it if you've got symptoms, signs, or a significant history. Save the CT scan for somebody else who needs it. And everybody doesn't need a 24-hour tape. Only if you've got a history or a 12 lead that's really suggestive. In that case, get a 48, get a 72-hour tape done, because you'll pick up more things. But just doing 24-hour tapes blindly on everybody who's tripped over is a waste of money and resource. But it's still really hard to stop people doing it. Now, everybody does need a urinalysis, but it doesn't mean you can blame everything on the dipstick when it comes back. Oh, UTI, stop looking. Do look, but keep looking. Again, smartphones may be incredibly useful here. They're very good at recording all sorts of data, and you can get them to measure up to 130 different parameters of movement: angles, angular velocities, acceleration, smoothness of movement, repetitive things. And there's really good models now been developed that from that information can predict very accurately the chances of somebody falling over. So the idea is, can you start to use these as a diagnostic tool, and then perhaps use them to encourage people to take up exercise and monitor the change in their movements as they're exercising and see whether they're improving or not. So it's got to the phase now where we have the predictive models. The next stage is the intervention from those. And I think there's a lot of interest in that area, so I think that's going to come through and be very helpful for us. I like mnemonics. I don't know if you do. DAME is a useful one for remembering what to look at when you're thinking of all the different things that can make someone fall over. DAME is particularly useful because women fall over twice as often as men. Do you know that? Have you been taught this?
Yes.
So you know the answers, so you keep quiet. Why do women fall over more than men? And these are theories, it's hard to test them. And it's not that there's more old women, it's allowed for that. You take that out, they just do fall over twice as often. Come on, have a guess.
Low blood pressure?
Low blood pressure? No, they're pretty much the same. Absolutely, so that's one good reason. When men retire, they sit still because they've worked hard all their lives and they need to rest. I didn't say that, don't tell Fiona. Women of the retired generations that we're seeing do not retire. They may stop going to work, but they continue to look after the house, and you can actually put pedometers on them and they're on their feet a lot longer than the men. So they have greater opportunity to fall. So that's one reason. And then there's two others that are hypothesized. One is that on average, men are stronger. There is overlap, obviously, and you need muscle strength if you're starting to fall to be able to correct yourself. And the third one is the way you stand, and that's to do with the shape of the pelvis. So if women stand with their feet together, therefore their base of support is very narrow. If they start to wobble, the center of gravity goes over. Men like standing like this, don't they? You see it all the time. There was a bunch of Germans around the swimming pool in the hotel this afternoon, and they're all like this. I should have photographed it. It would have fitted in here perfectly, but there is this difference in stance. And the three reasons probably together start to explain why women do fall more than men. But it helps to remind you of DAME. So drugs and alcohol are obviously important. Do ask older people how much they drink, because they like to drink just as much as younger ones. And the effect is greater. So I had a patient, he was an ex-Grenadier Guard. He had a scotch every lunchtime when he was cooking his dinner. He lived on his own. He'd done that for years. Suddenly he started falling over in the afternoon. Solution was to ask him to halve the amount of scotch he was taking, and then he was fine. We weren't going to tell him to stop because he would have ignored us, but if we suggested he reduce the amount, then the impact was less. So it worked for him. Medications are important. Interestingly, 4 is a critical number. Once you're on 4, your risk goes up, and it doesn't matter what they are. Some are obviously high risk, antihypertensives, going to give you postural hypertension, sedatives, and there are all sorts of sedatives, antihistamines, antiemetics, all of these will knock you out. And the rule really is, if you don't know why it's there, get rid of it, cross it off, because it probably won't cause any problems, and if it does, it will be apparent you can start it again. So cut all the drugs out. Aging has its own impacts. Remember who this pair were, the Chuckle brothers? Vision decreases, as we've said. Vestibular function goes down with hearing. Proprioception, you need to move more and able to appreciate that movement, so you're nearer the fall before you're aware of it. Muscle strength declines. Cognitive function is slower. Now, that doesn't matter in complex decision making, but it matters in speed, which is why we have fighter pilots who are young, and we generally have judges who are older, because they can often deal with more complex decisions because they take their time over it. There's a role for everybody. Medical causes is basically anything you'd like to think of. It can be a marker. Those that lose consciousness, they're the ones that as medics we really need to get stuck into. Environment, not a problem you have here a lot unless they go up the mountains, but those of you who come to work in the UK, we get frost and ice and snow every winter, and they all go sliding. Things you can either get rid of it, get it all hacked up, get the ice down, or you can give them walking sticks with spikes in. And there's a good study from Scandinavia to show that that reduces your falls rate. Mats, electric flexes, low furniture, great way of keeping older people trapped. So I used to have an outpatient that had these ridiculously low chairs, but they weren't going anywhere, so I could take my time. They couldn't go home. Bed rails, I don't know what the use of bed rails is here, but they should always be risk assessed and used appropriately because they are very dangerous. Catheters are great for twisting around and falling over. Wet hospital floors, all of these things are hazards. A couple of novel treatments I just wanted to mention at the end, because you may not have come across these, and I think they're potentially very exciting for future research. The first one is myostatin inhibitors. Now, growth hormone has been tried and tried again to try and increase muscle bulk and reduce falls rates. It hasn't worked. There's the odd trial where people think they found a breakthrough, but overall it really hasn't worked giving growth hormone supplements to people. Unless you're actually growth hormone deficient, that's a different matter. But for normal physiological levels, which do go down and change with age, boosting those up doesn't really seem to make a difference. However, there's some animal and phase 1 studies on myostatin inhibitors. I don't know a lot about myostatin inhibitors, but I know what they do. They stimulate protein synthesis, they increase muscle fiber hypertrophy, bone density, and they decrease fat tissue. So they sound like good guys. There's a paper that's come out now in Lancet Diabetic where they're showing increase in older people over 75 with muscle weakness, recent history of falls. They can increase their lean body mass, reduce their fat rate, improve their walking and stair climbing and chair stands. What we now need are bigger studies actually looking at falls and fracture incidence. But it's really interesting and hopeful that there's a potential to reverse some of the features of frailty with this drug. But very early days, but exciting. And then the other one is methylphenidate, which you may have come across as a treatment for ADHD. If you give this to older people, it increases their executive function, it improves their gait velocity, and reduces their gait variability. However, it has a very short half-life, so that's a major problem, and it comes with an awful lot of horrible side effects. So it's not really usable as is, but it's possibly a target for future drugs that you may be able to get that are cleaner, longer acting, and without the same side effects. So the idea that we can start to prescribe medications that may improve gait as a physician is really quite exciting. So it doesn't mean that physios get to do all of the good work. We might actually have something we can treat. Conclusions: most falls occur moving and changing posture. They're not syncopal events. 85% multifactorial. Strength and balance is key. Small numbers require specialist evaluation, but they do really need it. And then there are some really interesting novel assessments through personal devices, etc., and some interesting drugs that may come through onto the market in the next, I'll say 10 years, because it always takes much longer than you really hope it would, wouldn't it? And I'll stop there. Thank you.